So can we have the questions if there are any from the audience, and then I can ask a few more from both of them.
Yeah, Dr. Manisha, can you just put up the questions for Dr. Shobna so that she can take up to Dr. Lokesh and Dr. Avinash?
Okay, so then let me just put in a very simple question to both of you. Uh, the first one is in a patient who comes with this terrible epigastric discomfort, how do you decide which symptom tells you that this is going to be EPS or PDS? You both described it in great detail. So, how can you just, in a short, in 2 minutes, while the patient is talking, you decide this patient has delayed motility, this patient has an accommodation problem. So, Dr. Lokesh, since you talked about pathophysiology, what are
Now,
the questions you ask the patient?
so I'll ask the patient whether the patient, what is their predominant symptom, whether it's a burning
Hmm.
sensation in the epigastric region or pain, or whether when they eat something, even with a short meal, they feel like early satiety. And the other part
Yes,
is postprandial, what time the postprandial discomfort start and what time it persists. So these four
right.
leading questions sometimes lead us to whether what kind of phenotype we are dealing with.
Yes,
So if it is early satiety, then definitely fundic relaxation failure. Or if there is a postprandial distress or discomfort within 30 minutes of onset, I mean after intake of food, that indicates more in favor of PDS compared to the bloating and discomfort even we experience in IBS patients also. So that
yes.
is really late onset. So I think these four symptoms will definitely leading questions will help us to delineate to some extent.
Very good. I think that's a wonderful answer. In fact, there are some studies which, if Manisha does not have any questions, just talk about this. So you did talk about, uh, the accommodation tests. So sometimes, you tell the patient to have a little bit of water, see what he feels like, have a little more of water. And there is a test to do, a way to do this. And sometimes, even without their knowledge, patients might actually have 200 to 300 ml. So part of this lack of relaxation may actually be, functional, and they are unable to just relax their fundus. Yes, so that's very important. So many of these patients also sometimes lose weight because they're not able to complete a full meal.
Mm.
And as you directly pointed out, that weight loss, then you directly have to do an endoscopy to rule out a fundic malignancy. So Dr. Manisha, any questions?
She has posted few questions in WhatsApp group, madam. Can I read out, madam?
No, she
Probably.
said she would. She said she would read them out. So I'm waiting for her to read them out. Okay, I will read them out then. Okay, she must have
I
sent
think
it to me
she's
also.
pleased with, she has some connection issues, so she said that.
Okay,
Uh,
so if you, Dr. Lokesh, if you have
yeah,
them,
yeah,
please,
yeah. I
please
can
put
see,
them
madam.
up and we can.
So the
Yes.
question is from Rohan V, where they say like, how important is the duration and frequency of symptoms in diagnosing functional dyspepsia according to current Rome criteria, Rome 4?
So very good. I think that you can take this question, Dr. Lokesh.
So it's basically like to exclude the transient illnesses, especially like gastritis, post-viral, or sometimes NSAID induced, or some other transient acute gastritis. They
Hmm.
kept a time period, and also for evaluation of a chronic illness and labeling a chronic illness, functional disease, we need a time period. Many diseases, many symptoms will persist for 1 to 2 months and then subside. So they kept at least minimum 3 months, and the answer should be 6 months prior to the labeling diagnosis. This is why they kept a time period.
And another reason, Dr. Lokesh, is that many of these patients who may be missed as a serious illness. So somebody has an illness for 1 month and starting at an older age, we should not be thinking of functional disorders.
Absolutely.
Somebody who's a 50-year-old or a 60-year-old person comes for the first time with what looks like functional dyspepsia. There is mild weight loss, lack of appetite, and if they are treated as functional dyspepsia, then for a few months they get, mild relief, and they may not be seeing the doctor, and we may miss a serious problem here. So that 6 months is their minimum to call it functional. Less than that, in an elderly person with alarm symptoms, they should be investigated immediately.
Yeah, madam,
Yes,
but
tell
I
me.
think the majority of the guidelines are from the West, madam, so where the access to the endoscopy is much lesser. So in India, like we have now
Yes.
many gastroenterologists are doing endoscopy. So majority of the time they will come with an endoscopy report saying that they are not responding. So like I think
So that's a very valid point, but sometimes what happens, the patient delays the investigations
yeah,
and say, I have symptoms only for 15 days, I have symptoms only for 1 month. And that is where the dangerous part is.
yeah.
I'm not saying that get the endoscopy done in, say, a week of symptoms, but I would definitely suggest that don't wait too long because you're going to miss a serious disorder. Yes, Dr. Manisha.
So the second question was about, these are very generalized question, but important from the practice point of view, that patients often overlap with FD symptoms and IBS. If yes, how do you clinically differentiate between two in the routine care?
I think he's
Yeah, why don't you take it, Dr. Avinash? I think
yes,
Dr.
madam. So
Lokesh
like
is.
I think very important question in day-to-day practice, like predominantly in postprandial fullness, like it is predominantly immediately after having a food, that is 30 minutes after. So that typically points out to the gastroduodenal dysmotility. In IBS, there can be a chance of small intestinal dysmotility, or there can be a overlap of small intestinal bacterial growth, where there can be a chance of bloating, similar like more gaseous symptoms. So like predominantly whenever it is much farther away from the meal, then we think that it is a irritable bowel syndrome. Second thing is predominantly in irritable bowel syndrome, it starts with abdominal pain. So like that is the clinching diagnosis for IBS. It is not predominantly the burn. So here in functional dyspepsia, it is predominantly the burn that makes, and it is predominantly the meal relation immediately after the food. So that is what differentiates it from the IBS. But saying that both the things are predominantly disorders of gut-brain interaction, so they come under an entity of functional bowel disorders. So predominantly the upper GA1 is the functional dyspepsia. Predominantly the lower can be the irritable bowel syndrome, which has got the relation with the bowel frequency or the consistency. Anything
Yeah.
else?
So the main thing is that in IBS, there will be some form of either constipation or change in bowel habits, which is very important. And in at least 40 to 50% of cases, there will be patients of IBS will have symptoms of upper GI tract. So it's never, you cannot divide the bowel and say that if there are gastric symptoms, there will not be any bowel symptoms or vice versa. So, you have to balance them. Okay, next question, Dr. Manisha.
Yes. Ma'am, very interesting question actually has come, that somebody is asking about, is there any change in the representation trend over a period of time this year? Like perhaps due to dietary habit change or H. pylori, increased prevalence of H. pylori, or any stress level associated with it. So is there any change in the trend?
Not that we are aware of, but overall, if you see the whole Indian population, a lot of us have H. pylori present. And patients who come to us get it eradicated, but the rest of them continue to have their H. pylori. So over a period of say 20 to 30 years, the H. pylori prevalence will go down because we now have access to clean water and clean food. And people are moving towards that, clean water and clean food. So that will make a difference to H. pylori. But when you add to it the changes in diet and the changes in stress, the number of patients with functional dyspepsia will probably remain the same. So we are not going to be changing much of that. Dr. Avinash and Lokesh, do you think there's something different you want to add?
No, madam, I'll go with you.
Okay,
Because the
thank you.
prevalence is coming down, but most of the time, because the fast food centers have increased and a lot of dyspepsia secondary to food intake, like food habits as well as timing, as well as high fatty food and high calorie food, we are getting more and more dyspeptic patients.
Absolutely, correct. Yes, Dr. Manisha.
Yes. There is one question, ma'am. There is a role of screening for food intolerance or dietary pattern. And how useful is the dietary modification in the real world practice? Is there any
Dr.
association?
Avinash.
Yes, madam. So it's a very important question because a lot of people will be already on a restrictive eating habits. So it becomes very difficult for us to convince that those items are not going to impact because that is what the textbook tells. But majority of the time, because at the end the patient is the boss. So the thing is like if they identify that this is a trigger, and we just tell them that if you keep on restricting, then the nutritional component may have a problem. So, we just explain them that it is a trick of moderation. So, they may have to figure out rather than 0 and 100, try to reduce on it and then take it from there. Second important thing is it's always better to have a microscopic anatomy, that is endoscopy plus a duodenal and a gastric biopsy for ruling out that whether the person actually has got an eosinophilic or a celiac. So anything which can imply or implicate a dietary modification as far as the etiological perspective is considered. But it is a very important question in a day-to-day practice. Yes, madam.
Correct.
As such, I mean, I want to add one more point, madam. When you look at the pathophysiology, there's been, hypothesized that there is increased eosinophils in the duodenum and IEL cells. There is some amount of inflammatory activity happening in the duodenum in all dyspeptic patients. I mean, to certain patients, certain percentage of patients. Probably the food may be a trigger, like how the celiac, it's not a non-celiac kind of gluten hypersensitivity or some kind of FODMAP triggers could be a possibility. So in such a case, we can recommend, as sir said, they can tailor their food habits based on the triggers, and it's not like blanket statement. But we have seen certain, functional dyspepsia patient not responding. We had a drug like LDCET or some other drug or TCS, they respond well. There's some visceral hypersensitivity, food could be a trigger.
Right. So I'll just add to this that when a patient of functional dyspepsia does not respond, it's important to get the D2 biopsies, take biopsies from the second part of the duodenum and also sometimes the stomach if you find abnormalities, because these patients may have eosinophilia. And if that is there, then we should look at foods that could trigger it. Unfortunately, patients start avoiding these foods on their own. They will start avoiding certain vegetables, proteins, and then they actually become deficient. And that is something that we have to be very careful about. So very happy this question has been asked. We've got to be careful before we advise patients blanketly that, you stop all these items and then you will get better. They don't get better, but by then they have become deficient. So we got to be careful. Dr. Lokesh,
Yeah,
are there any
I'll see,
more
madam.
questions that you have found?
No, madam, I
Yes.
think we have answered all the questions, madam. Role of screening
Okay.
food intolerance, and yeah, we have answered, madam.
Okay, so that's wonderful. It was a big learning session for me also, and I'm sure the audience definitely learned from both of you. I'm very happy that this session was taken.